Hi there.
Hello, can you hear me?
Yes, absolutely. I can. How are you doing?
Perfect, perfect. I was just talking a bit with our attendees here, just explaining what the topic is going to be for our talk today. My name is Beatrice, and I'm working with the FP. So I would like to thank you for speaking with us today, and also say sorry for our delay for the problem with the link, but now everything is sorted out. So yeah. Would you like to present ourselves for the people who don't know you yet?
Yeah, sure. Can you see me? I can see my generic picture.
I can hear you perfectly, but I can't see your video.
All right. Let me try. What am I supposed to? Oh, is it better now?
Perfectly. Perfectly. I can see you now. That's perfect.
Yeah, brilliant, brilliant. Okay, so let me just tidy up my computer. Right.
Okay.
Hi.
Hello.
Sorry about the delay. We have a storm here in Greece tonight, so there was an internet delay. We had complete shutdown 5 minutes ago, so sorry about this. So good evening, everyone. My name is Dr. Tsakos. I'm not going to keep you very long tonight. I know it's getting a little bit late, so thank you for attending and thank you for organizing this event. I was hoping to get some slides up as well for you tonight, but
yes, I have here a presentation. If you want me, I can share it.
Okay, I will try and download a few things now, but as I said, the internet's very slow because of the storm.
It's okay. It's okay.
I will talk for about 20 minutes regarding fertility surgery and how would fertility surgery, how can it help our fertility couples. And this is a topic that's very interesting because over the years, we have seen that with the progress of IVF, fertility surgery has been seriously phased out and has not become very popular. And in my opinion, this is wrong because the fact that we can treat with IVF many couples doesn't mean that we shouldn't be offering them the choice and the option of fertility surgery. And when we say fertility surgery, in essence, we mean endoscopy. So it's not real surgery. It's not. It doesn't involve cuts and incisions and the use of scalpel. It involves the use of endoscopy tools through which we can look into the woman's body and, of course, correct any minor or major anomalies that affect their fertility. So in the old times, maybe in the 80s and 90s, laparoscopy was absolutely obligatory before resorting to IVF, and that was the norm at the time. Now, with the progress of IVF, we tend to forget the value of laparoscopy and hysteroscopy in that sense, in improving and facilitating both natural conception and assisted conception. So I think the message for our viewers tonight is that depending on the etiology, on the reasons for your infertility, please do not forget the value of endoscopy. Now, which are the areas of fertility that endoscopy could be valuable? Frankly, everything. So there's no particular etiology of infertility that is not an indication for laparoscopy, for example. So in cases with suspected endometriosis, in cases of tubal factor, in cases of fibroids, polyps, unexplained infertility after a miscarriage or after a failed IVF, endoscopy surgery may provide a valuable tool for our patients, and it should be heavily considered. I mean, of course, there are some implications associated with that. Of course, it's not easy to have endoscopy. And again, I refer to endoscopy. When I refer to endoscopy, I mean hysteroscopy and laparoscopy. If I want to make a little bit more clear, to make it clear for our patients tonight, hysteroscopy is the examination of the uterine cavity, and that is an outpatient procedure. It doesn't involve any cuts, any incisions, and it's providing us with valuable information of the cavity of the uterus. and the inner lining of the cervix. Why is this important? For various reasons. One is that the scanning alone doesn't always differentiate a normal and an abnormal uterus. Despite the advent of the technology in scanning, we still are very far from identifying 100% of the anomalies of the uterus. And of course, this can be very important in our fertility patients. So in the workup of fertility, in my opinion, the anatomy has to be absolutely scrutinized by means of hysteroscopy. And of course, the same applies for IVF couples. So hysteroscopy doesn't make our couples or our patients avoid IVF. However, invariably, it makes IVF more straightforward. It eliminates the chances of anatomy pathology like polyps or diaphragms or adhesions and so forth. And even minor anomaly like cervical stenosis may be implicated with a difficult embryo transfer and a possible failure in the IVF. So, in my opinion, hysteroscopy is very high on the priority list for both fertility investigations, but also essential fertility workup prior IVF. Of course, this acquires an even bigger importance when it comes to previous failed IVF, and in particular implantation failure or miscarriage. So hysteroscopy has to be there as a valuable tool in assisting either natural conception efforts for patients or assisted conception efforts. Now, when it comes to laparoscopy, laparoscopy is a more complex procedure compared to hysteroscopy. It involves general anesthetic. It involves small incisions, keyhole incisions the size of my pen, through which we enter the abdomen and we examine the pelvic organs. And by doing so, we can eliminate some factors that may be associated with failed IVF, for example, endometriosis or adhesions or tubal adhesions, which may be associated with ectopic pregnancy in the future. We can eliminate conditions like hydrosalpinx, which is the accumulation of fluid within the tube, which is a potentially dangerous situation for both the health of the woman and the health of the pregnancy. And furthermore, with laparoscopy, we can differentiate really the women with unexplained infertility. I mean, it's very common to have couples with unexplained infertility, and those couples, those females, they haven't been investigated with laparoscopy. So how can we classify an infertility as unexplained if we haven't ruled out endometriosis or tubal adhesions and so forth? So this is the spectrum of endoscopy, hysteroscopy, and laparoscopy. Over the last few years, over the last 10 years, 10 to 15 years to be accurate, a new mode, a new method, a new model of laparoscopy has evolved, and this is robotic surgery. And robotic surgery involves the use of high-end equipment and high-end technology and software, through which we can perform complex gynecology surgery through keyhole. One of the principles of surgery overall across all specialties in the last 20 years has been the conversion to minimal access surgery and the avoidance of laparotomy incisions. And with robotic gynecology surgery, we can achieve that to a very huge extent. Probably more than 95, 98, 99% of our patients can be managed through keyhole surgery with the use of robotic surgery for complex cases. So robotics is giving us the confidence, if you like, that we can complete complex and challenging operations on the female organs. And this, of course, acquires an even higher importance when it comes to fertility, because restoring someone's fertility is not always an easy task. And with robotic surgery, we can achieve that. So which factors do we eliminate? we can operate on large fibroids that distort the uterus, distort the uterine cavity. Operating on fibroids on a woman who wishes to become pregnant in the future is a huge challenge for the surgeon, because there's always the risk of a rupture of the scar in the future when the uterus enlarges during pregnancy. And of course, it has to be performed with the highest standards, and robotic surgery is giving us that confidence. And of course, tubal factor infertility is another challenging field that in which robotic surgery has a huge application. And by doing so, perhaps we can operate on some tubal, previous tubal sterilization cases that up until now we were referring straight for IVF, and perhaps we can consider for the young patient with normal sperm count on the partner in normal hormonal status, we can offer them the option of robotic tubal anastomosis. Now, there's other areas of robotic application which I'm not going to go into now. However, I can just mention oncofertility, which is the preservation of fertility in females with oncology issues, and of course transposition of the organs of the ovaries, so we can move the ovaries outside the field of radiation for cancer patients. And if I wish to become a little bit prophetic, a little bit futuristic, I would say that maybe in the next 5, 10, 15 years, no longer than that, most, if not all, the uterine transplantation procedures will be performed by the robotic technology. So I think this is an overview of the value of endoscopy. So in summary, endoscopy involves hysteroscopy, laparoscopy, robotic surgery. The value of endoscopy in fertility care is undisputed. I think we should remember that. Firstly, when we make a diagnosis of the fertility reasons of our fertility couples, and furthermore, when we consider IVF, prior to IVF, perhaps a hysteroscopy has an important value and place, and certainly after failed IVF, it has an added value.
Yeah, so we've seen that, there's a lot of options for different people with different diagnoses. There's different techniques that we can use, and definitely there's this new area of robotics that makes it less intrusive, more precise. So there's a lot of pros going into it. And for our audience who isn't, medical personnel, they aren't as experienced with this kind of talk, how would you say that, for example, fertility surgery would help patients with endometriosis?
Well, absolutely. There's a lot of ways. I mean, firstly, endometriosis, in my opinion, is very important to diagnose. So in vast majority of, perhaps as high as 50% of the infertility patients, they suffer from endometriosis without knowing. So initially, we need to make a diagnosis. And after that, of course, we can eradicate the endometriosis by surgical application of techniques, either removing the endometriosis or lasering the endometriosis or using the diathermy. And of course, this is giving us more insight into how to manage that case. So endometriosis has to be diagnosed. First of all, we have to be suspicious that there may be endometriosis in an infertility patient, even if they don't have any other problems, any other symptoms apart from infertility. Very often infertility is the main symptom, the main reason, the main way that we diagnose endometriosis, and then to treat it. And then, of course, there's cases of endometriosis which is more severe, which produce either major symptoms that affect the woman's everyday life, like pain or dysmenorrhea or menorrhagia sometimes, or painful intercourse. And of course, that has to be alleviated in the course of fertility, the overall fertility care. And also, there are, apart from the deep infiltrating endometriosis, there may be endometriosis cysts on the ovaries, which, depending on the size, location, characteristics, They have specific indications for surgery. We tend to ignore, of course, not to operate on small cysts. However, we tend to possibly operate on larger cysts, perhaps larger than 4 to 5 centimeters, especially the ones that are affecting the quality of the ovulation, the ones that are blocking transvaginal oocyte pickup and so forth. So endometriosis and endoscopy is a huge chapter. I'm very passionate about it. I have been fortunate enough to have been trained in the UK by some of the best people in endoscopic surgery and infertility associated endoscopic surgery for endometriosis. And it's a challenging issue. The good news is that there's a lot of options that endoscopy has to offer.
Great. That's exactly what I wanted to hear, that there are options, so our patients do not have to live with it. And it's definitely something that you should check and get into if you want to see resolved. Another topic that's very common amongst our patients is blocked tubes. So you already touched a bit on this topic, but how would you say fertility surgery would, correct or help with blocked tubes?
Sure. I mean, the principle of medicine is to improve a patient's health and improve the patient's well-being. And of course, when it comes to fertility, in my mind, the principle should be to improve the natural fertility first of all. So, for example, it's very common to see someone having an HSG, which shows blocked tubes, and then they move on straight to IVF. Well, out of those couples, out of those patients, some may really not have really blocked tubes. They may have a spasm on the tubes, or they may have very, very flimsy adhesions that are causing the blockage of the tubes, or maybe the technique has not been correct that performed the HSG and so forth. So I think we should always consider a laparoscopy, for example, to double check the diagnosis of blocked tubes on X-ray or on hysteroscopy. This is something that doesn't happen very often. And why does it not happen? Because most of the fertility specialists trained in the last 10, 15 years, perhaps they trained in fertility medicine and not so much in fertility surgery. So perhaps, IVF is what most people in fertility clinics have been trained in. And therefore, this is the easy way out. Blocked tubes equals IVF. In my opinion, blocked tubes equals consideration for laparoscopy. Of course, if we have a 42-year-old or a 44-year-old or a 35-year-old with a husband or partner with abnormal sperm, yes, maybe a laparoscopy should be considered, but eventually not performed because that couple will eventually end up in IVF. However, we should discuss that, in my opinion. We should counsel our patients, and there's always a little bit of value there if we do a laparoscopy. Firstly, to diagnose blocked tubes, to ensure if they're blocked or not, and secondly, to explore the option of improving the condition of the tubes.
Yeah, it's very interesting to see that we have different paths that we can go on, depending on other factors like age and other factors like the male factor of fertility. So it's definitely very interesting to not have a one-size-fits-all answer. And that's why it's very important to have our attendees be here and actually hear the experts explain these kinds of topics. And the last specific problem that we would also like to talk about is how can fertility surgery help with fibroids? It's also a very common problem. So what would you have to say about that?
Sure. The fibroids are very common benign tumors of the uterus, and they become commoner, of course, with advanced reproductive age. So when a woman grows older than 35, older than 40, the chance and likelihood of developing fibroids is higher. The big question and the big challenge is which fibroids do we operate on? There's the black areas, the white areas, and the gray areas. So let's start with the white areas. So if someone has a small fibroid of 2 centimeters, 3 centimeters, which is outside the uterine cavity, outside the endometrium, perhaps on the external part of the uterus, which is not causing any problems, we can consider leaving that without surgery. So this is the white area. The black area, so fibroids that we would definitely suggest surgery, are large fibroids, larger than 5 or 6 centimeters, multiple fibroids that are damaging and distorting the myometrium, which is the muscle layer of the uterus, fibroids that are within the cavity, they're called submucous fibroids, and therefore they would interfere with the implantation of the embryo, and more often than not, they produce heavy periods and painful periods. So those are the ones that we would definitely seriously consider removing them. And then we have the gray area, which is medium-sized fibroids, a little bit touching the cavity, but not exactly intruding into the cavity and so forth. And in those cases, again, we would have to consider the option of either leaving them alone or operating on them, especially if there's other associated infertility factors. Now, the way we operate on them, unfortunately, still a good proportion of those cases are operated on by laparotomy, which in my opinion has to be phased out. However, laparoscopy is becoming more and more popular, and now with robotic surgery, we hope that even if we need to perform surgery on anyone with fibroids, we would do that through keyhole surgery.
Yeah, so it's as you said, so everything is evolving, robotics is making it easier. What would you say are the main risks that women can face when going into fertility surgery? And what would you say to a woman who's fearful of doing surgery, but you consider that she needs it?
Well, it's not easy. I mean, it's everyone is afraid of surgery, and this is natural. However, I mean, all we need to say at the moment is that the vast majority of our fertility patients are young and healthy. So what we call low risk of patients for anesthesia and for surgery. And with the advent of new technology now, and with experience and skill, the serious complication rate of endoscopic surgery is very near 1 in 1,000. And the minor or medium complication rate is in the region of 1%. So it's pretty safe surgery. And of course, in the journey to parenthood, it may contribute in the success either via natural conception or via assisted conception.
Yeah. So what would your main advice be for women who are actually considering surgery?
Well, trust your surgeon.
Yeah.
That's my main advice. And well, look up your surgeon. I mean, sometimes it's not difficult to find out who is experienced and who's not. Now, surgery is, in my opinion, is a skill that some people acquire through training, but of course it needs a lot of retraining and a lot of keeping up to stay on top of that skill. It requires an experienced team. It requires a very high-end facility that provides that safety and confidence to the team and to the patients to go through surgery. So my bottom line advice is trust your surgeon. Find a surgeon that you can trust and let them do what's best for you. Now, if they are reproductive surgeons, which is becoming more and more rare now, unfortunately, because the majority of gynae surgeons are just gynae surgeons or oncology surgeons, and they're not exactly what we call reproductive surgeons. However, if they are reproductive surgeons, of course, they would have a little bit of more rounded approach into the reproductive surgery strategy and, of course, skill. If they're just surgeons, gynae surgeons, perhaps oncology or very experienced endoscopy surgeons, but not specifically reproductive surgeons, I would strongly suggest that they discuss with your reproductive endocrinologist, with your fertility specialist, in order to identify the indications and in order to define the strategy for the management.
Yeah, definitely we want a healthcare professional who we can trust, We want someone who we consider is able to do the surgery. So I would definitely agree with that. So not jumping into it, thinking about it, but being certain that it's going to be okay and that it is going to help you. So the ultimate question, we've already answered this, but surgery actually improves the chance of success with IVF treatment, correct?
Yes, on certain under certain indications, it may improve the chances of fertility and IVF care.
Okay. Would you like to talk a bit about?
Areas this is totally undisputed. In some areas it is a little bit debatable, but in my opinion, apart from it depends on how we define the endpoint. So unfortunately, it's very difficult to conduct scientific studies with such endpoints. It's almost impossible, and especially when it involves multi-center studies, because there's different standards, different patients, different populations, and so forth. So I think this is one of the real challenges in surgery today. I mean, for example, in IVF, it's fairly easy to conduct multi-center studies, to have same protocols, to apply same techniques and so forth. But in surgery, unless you have perhaps very, very strict criteria, and unless it's a one-center study with particular endpoints and so forth, it's very difficult to create evidence. However, in my opinion, we should always consider hysteroscopy, which is the standard, straightforward, non-invasive, day case, no anesthetic needed. It's an extension of an eye, if you like, a hysteroscope into a woman's uterus. So hysteroscopy, in my opinion, should always be considered for any fertility patient, and laparoscopy should be considered if there's specific indications.
Yeah, so we can definitely see that we have options, that we need a good expert, and that ultimately we can always be here to help you. So what I would like to ask you is, if any of our attendees here today wanted to contact you, how could they do that? You want to leave your contact information or your email for them?
Yeah, sure. I mean, you're very welcome to contact me on info@embryoclinic.eu, or there's lots of channels, social channels and so forth, or through your amazing platform. And I would be delighted to look at your notes and offer you consultation in the first instance online. I mean, COVID pandemic has had a positive effect, which has been the online events. I mean, we managed to get some people online tonight, which would not have been possible perhaps last year or 2 years ago. So there's a new concept now in fertility care. There's total globalization of care, and in a way, the pandemic has given us that blessing. But hopefully, we should be able to meet each other in person very soon.
Yeah, definitely. And so I would like to remember everyone listening to us that this is a support group. So if you do need support, use these tools that we're giving you. Do contact us if you need to. And I hope to talk to you again soon, and to have everyone listen to us as well, because it's a lot of information that's very useful. So yeah, I'm very delighted to have talked to you, and I hope to see you again.
Thank you very much. Thank you for the invitation, and congratulations for the amazing work you're
Thank
doing,
you.
supporting patients all over the world.
Yeah.
Congratulations. Thank you for listening, and have a lovely evening.
Thank you so much. Bye, everyone who's listening to us. Bye.
Bye-bye. Bye.